For the second half of our talk, now whatever I have discussed in the beginning, I'm going to walk through some cases that can help us evaluate how this information is processed and utilized in a kind of a real world evidence basis, which means that we are going to discuss two cases and see how various different precision medicine based discussions are done. Here I'm going to focus on ctDNA, which is like circulating tumor DNA from liquid biopsy, how it can utilize. But NGS, where along with tissue biopsy, is going to be discussed along with this in the cases as well. So let's walk through it. First of all, looking at this figure, you can see that ctDNA is now utilized in multiple things. Cancer detection, it can help us in risk stratification of the cancer. Second, molecular profiling or prognostication. Then detection of residual disease after the treatment, sometimes after the surgery, as well as monitoring the response, whether the cancer is going down, is it going up, so on and so forth. And then also evaluating clonal evolution, which means that the cancer changes its type based on the treatments that are given as well. And this different precision medicine approach, biomarker testing in ctDNA can help us evaluate that evolution as well. So in first case, we are going to talk about cancer detection as well as molecular profiling for prognostication as well. So with this, let's walk into first case. 64-year-old male with a medical history of diabetes and hypertension who presented with sore throat, dyspnea on exertion and cough, and underwent a CT chest that showed an irregular mass in the left lower lobe, measuring around 3.6 by 2.3 centimeter. It was extending toward the hilum and multiple nodules throughout the lungs. And next step was to do PET scan, which showed that there was FDG uptake, which just means that there was more uptake in the pulmonary nodules, along with increased uptake in the liver and thoracic spine, which means or which indicates that the cancer had spread to the liver and spine as well. Biopsy was done and probably at the liver site, which confirmed that this was lung adenocarcinoma. Next thing was molecular testing and next generation sequencing was done. Initial next generation sequencing was just done from tissue, which showed that there was EGFR 19 L858R mutation. And then NCCN guidelines were looked at, which showed that frontline options can be osimertinib or osimertinib plus chemotherapy or amivantamab plus lazertinib. So it can be various. There are 3 different trials which have shown great benefit and outcomes as a frontline or the first treatment for such setting. And discussion was done on what next to be done. And next will be kind of hypothesis that how would discussions happen. So how would we approach when this patient progresses? Let's say if this patient received osimertinib, which is a FLORA trial. Then currently the second line's available option as of now, when we're talking right now in February 2026, it's amivantamab plus platinum doublet. It is based on Mariposa 2 trial, or it can be osimertinib plus chemotherapy, which is COMPEL trial, or ivonescimab plus platinum doublet. Or if there is a newer alteration found on progression, then targeted treatment can be given. And similarly, there are third line treatments based on those things as well, that what second line treatments were sometimes given. However, let's say if we gave this patient Mariposa trial treatment regimen, which is amivantamab plus lazertinib, then in those cases, second line treatment will be different. It can be platinum doublet plus EGFR TKI, which means tyrosine kinase inhibitor. It's one of the tablets with platinum chemotherapies, or ivonescimab plus platinum doublet, or new alterations. I would like to highlight over here, ivonescimab is still not currently available at different parts of the world, but this could be one potential approach as well, if all the approvals were there. And similarly, third line can be docetaxel, platinum doublet, or dato-DXd, which is an antibody drug conjugate. And let's say if we use FLORA2 approach, which was osimertinib plus platinum doublet, and in that case, amivantamab combinations can be given, which means amivantamab plus chemotherapy, or docetaxel can be given, or dato-DXd, which is again antibody drug conjugate, or newer alterations can help us give targeted therapies for that. And similarly, third line therapy usually remains similar, which is docetaxel or single agent chemotherapy. So you saw, depending on what first line treatment was given, the second line treatment will be decided based on when the patient progressed and if there were any new alterations and exact treatment which was given, because the approvals as well as current literature and evidence changes based on what first line treatment was given. So decision making, let's say in a similar way that this patient when progressed or a similar patient when they progressed, and we bring this case to multidisciplinary tumor boards. This is how the discussion would happen. We would look into first line. We would see if this is an oligo progression, which means there's progression just at one side, or it is stable or low burden progression, or there is rapid progression. In most of these cases, we would check and do tissue biopsy along with that liquid biopsy, and then evaluate if there was new resistance mechanism or alterations detected. So there are various mutations which are identified by this tissue NGS or by this liquid biopsy, ctDNA, which can indicate that the tumor in this particular patient is now having newer genetic mutations inside the tumor, which could be developed, which could be leading to resistance of the treatment that the patient was on. For example, just giving an example of osimertinib, there can be particular EGFR alterations or mutations which could be happening because now the tumor has developed resistance to osimertinib. So let's say if this patient had just oligoprogression. If it was just oligoprogression, then you can sometimes just do symptomatic and local radiation therapy. Let's say there was just progression in one of the spinal lesion. Then you just send this patient to radiation oncologist and they can do radiation over there while continuing the systemic treatment, which means the chemotherapy or the tablet that this tyrosine kinase inhibitor that the patient was already on. Second one is, let's say if it is a stable and low burden. Then preferred strategy can be given based on comorbidities, which means what other diseases does the patient have, ECOG, which is called performance status, how well is the patient able to do in his or her regular day-to-day life, able to walk, able to bathe, able to do regular activities, so on and so forth. And this is particularly, it depends on the what first line that was given. If there is rapid progression, very often we would evaluate for clinical trials. And again, this clinical trial discussions can happen in the site-specific or general tumor boards, or if we think that there could be phase 1 or phase 2 clinical trials, then we can send those patients for evaluation in the phase 1 meetings as well. At the same time, it's very important to have palliative care team evaluate the patient and work with the patient as well for various different symptomatic approach. And then depending again, similarly on comorbidities and performance status and first line, next steps can be given. Here, let's say if a patient had multiple different alterations where it could be targeted or newer therapies are available which can be used at 2 or 3 different levels, but there is no preferred approach in the guideline, then such cases can be taken to molecular tumor boards to discuss as well. So this is how we can walk through cases and we discuss in molecular tumor boards or regular tumor boards or in phase 1 discussion as well. Highlighting quickly over here some perioperative clinical trials as well, that various different clinical trials readout happened last year at World Lung 2025, as well as at ESMO 2025. And this showed that combination of neoadjuvant immunotherapy in combination with chemotherapy for borderline resectable as well as unresectable cases, even till stage 3, was having some improvement in outcomes as well, giving it as a neoadjuvant setting, which means before the surgery and possibly undergoing surgery as well. As well as there was another trial which showed tislelizumab plus chemotherapy followed by surgery or radiotherapy and adjuvant tislelizumab as well. At ESMO 2025, again, there was an interim analysis readout for MDT bridge study and another readout for surgery versus radiotherapy after induction therapy with sertolizumab combined with chemotherapy for unresectable stages as well. Why I highlighted over here? Because right now the pendulum or the treatment paradigm for non-small cell lung cancer is shifting in such a way that all the way till stage 3 unresectable cases, which means that those patients who would be deemed as not resectable because of their tumor mass can be given some treatment earlier on. Their mass can be shrunk and then could possibly undergo surgery or radiation as well. Therefore, with the newer treatment guidelines coming out, it's very helpful to bring most of these cases to tumor boards and discuss with surgeons, radiation, medical oncologists, and the full team together. With this, I'll move on to the second case. And here we are going to talk about three things. One is about molecular profiling or prognostication, which means risk stratification. Here we will also talk about detection of residual disease and monitoring responses. And at the end, I'll briefly touch base about monitoring clonal evolution as well. Here in this figure, you can see that when monitoring response comes, there's a serial liquid biopsies. So moving on to second case to talk about this benefits of ctDNA testing as well.